All right. Good morning, everyone. Thank you for your patience as we got started this morning. Thank you for joining us for our Zoom panel today. We're swapping it up today. We're not going to be talking about COVID care today. We're going to be talking about men's health. September is recognized as National Men's Health Awareness Month. And so we wanted to take the opportunity to discuss some different issues in men's health, particularly concerning the prostate. And so this morning, we have two of our panelists with us, Dr. Geary and Dr. Josh Perkel, who are both urologists, board certified urologists at Navicent Health. And we are going to go ahead and kick it off with you, Dr. Geary, and then turn it over to Dr. Perkel. All right, go ahead, Dr. Geary. Do you want to kick us off by telling us just the basics of men's health?
Sure. Yeah, thank you all for coming. Men's health is obviously an important issue as a urologist to me. What we're talking about today is the prostate, but not prostate cancer. Actually, it's going to affect more people, more men than prostate cancer will, because not all men will get clinically significant prostate cancer, but just about all men will get at some point in their life clinically significant BPH or benign prostatic growth. And the issue there is that it's the prostate, but also the bladder that actually has become an organ that matters to us in medicine more so than it ever has before. It used to be thought of as kind of the annoying upstairs neighbor to the prostate, and in women, the vagina. But now we're realizing that the bladder is actually very much like the heart. It functions the same in men and women, and you actually have to protect it long term, otherwise it'll quit working. And it will either turn into a big floppy bag, kind of like a dilated cardiomyopathy that doesn't work well, or a small squeezy muscle, kind of like a hypertrophic cardiomyopathy, the kind that, bad heart disease either way. So the downside is for men, which is usually most of my patients' biggest fear, is that when the bladder quits working, then you have to drain the bladder with usually a Foley catheter. And that's, in my experience, what most men fear, is having to have a catheter hanging out of their penis. And that's kind of where all this comes in, because, probably about 30, 40 years ago, when you came to the urologist and you were having trouble peeing, you'd say, hey, doc, I'm having trouble peeing. And they say, well, is it bad enough for me to do a TURP or roto-rooter you? And they'd be like, no. And we say, all right, we'll come back when it gets that bad, because that was all we had. And everybody thought it was all the prostate. Then the medicines came out, and the pendulum swung to the other direction, where TURP went from one of the most common procedures in the US to almost never being done, because they thought, well, you won't ever need it because you're on these medicines. And now what we know after 20, 30 years of guys being on just medicines is, like I said, the bladder is its own organ. And when it quits working well, you suffer. And all guys are going to have trouble with their prostate. If you were to kind of slice things in half, the prostate sits right between the bladder and the tube that drains the bladder or exits through the tip of the penis, called the urethra. And when you cut across it like a loaf of bread, it looks kind of like a donut hole. And there's no fault, and I tell this to all the patients' wives, it's not their fault, not that they didn't eat anything correctly or eat too much of something bad, it just grows. And when the prostate starts to grow, that donut hole starts to shrink, and then the bladder has to work much, much harder to get the urine out. So it's kind of like hypertension in a way. And so that's all we, when prior to UroLift, it was, and I'll let Dr. Perkel talk more about that. But what happens is, guys, the problem with men and with BPH management is guys just assume that it's part of getting old, to not have to, your stream's not quite as weak or not quite as strong as it used to be. You start having to strain a little bit to get your urine out. you know, you start having to go way more often than you think you used to, and having to go and it hits you kind of out of nowhere. Those are all the symptoms. And then night, and then you start, once the bladder kind of gets past a certain point, you may even start leaking. And so I see a lot of guys that can't even wear khaki pants anymore because they have a little bit of drips of urine, or they know where every bathroom from here to wherever they're going is, which is called bathroom mapping. Or they carry a jug in their car or truck so they can pee because it's going to hit them out of nowhere and they're not going to have time to stop. And some guys will come to the doctor. Sometimes their wives drag them to the doctor because they're tired of dealing with it. But ultimately, every guy will come to the doctor because either they can't see or they can't pee. And we'd like them to all know that, you know, there are things you can do to help that aren't as bad as what everybody always thinks they would be. And I'll let Dr. Perkel talk more about that. Unfortunately, got one of our patients. Josh,
Yeah. So I'm Dr. Perkel, and I appreciate Dr. Geary giving us the background about BPH, or benign prostatic hyperplasia, which is prostate enlargement. And we're very excited. Dr. Geary and I actually just achieved special recognition for performing and tracking our data on a large cohort of patients with a procedure called UroLift. So I'll tell you a little bit about that data in a second, but up until this point, up until UroLift was available, we had medicine and we had surgery. And Dr. Geary was talking about a lot of guys don't want to go to the doctor because if they see their regular doctor, maybe if they're willing to go. So there were medicines, but the problem is the medicines didn't fix the condition. They might take the edge off the symptoms if they work. They have side effects in some men, fatigue, dizziness, and sometimes sexual dysfunction. So if they really weren't ready for a surgery, they might not bring it up to their doctor, or they might not be happy with their medicine, but they just stick with it. UroLift is a procedure that can be done in about 30 minutes or less. It can be done under a very light sedation. And it basically, rather than heating or removing the obstructive tissue, when Dr. Geary talked about a donut with the donut hole, and the surgery clears out the middle, the UroLift just pins back the lobes. So it actually opens the channel, kind of like if you had curtains covering the window. You pull back the spongy tissue like the curtains, and then you pin it open. And it's done through a unique device that goes right through a scope. There's no incision. You don't have to use a laser or a cutting instrument or anything. And the landmark study that the company presented to the FDA showed a 50% reduction in symptoms. And we actually have a validated survey. It's 6 questions. It's easy. It's called the International Prostate Symptom Score. And there's 6 questions. And when they did patients pre-op and post-op, they were amazed that they had a 50% reduction in symptom scores, which is really good. The medicines don't come close to those reductions. And when Dr. Geary and I tracked our data through 60 patients, we had a 65% reduction. So we found that in clinical practice, when we got very good at this procedure, we had a greater reduction than the landmark study with our 60 patients. So there's really nothing for men to be afraid of if they're having these urinary symptoms, if they're carrying a jug in the car or the truck, or their bathroom mapping like he described. If they're a candidate for this procedure, it's quick. There's not much of a recovery. A lot of times it can be done even without a catheter. And so there's really very little downtime. The risk of side effects or complications is extremely low. As a matter of fact, the sexual side effect wasn't even reportable because there really were no sexual side effects, which a lot of the other prostate surgeries or medicines do have significant side effects. So UroLift is a very interesting procedure. It's easy to recover from. Most men with enlarged prostates are a candidate for, and it works very well. Who is a candidate? Well, for men that have side effects on medicine, or don't want to take a medicine every day, or they just want better relief than they're getting on the medicine, those men are candidates. Most insurance covers it, including Medicare, so cost really shouldn't be an issue. Access is here. And really, the patients are the biggest advocates. We have patients who read about it. They go to the website. It's easy to remember. It's Urolift, urolift.com. And there's videos and information. And they come in and they say, you know, can I have this procedure? Am I a candidate? And it's really starting to take off. There's good FDA approved studies and data out there. So it's here to stay, and it's a great procedure. We've helped a lot of people with it.
Thank you, Dr. Perkel. So we do have a patient. You're talking about so many patients that have been helped. We do have a patient with us this morning, Tony Hogsett from Warner Robins. Mr. Hogsett, thank you for joining us. Do you want to share, your experience?
Yes, please. Can you hear me okay?
Yes, sir, we can.
Okay. I've been seeing Dr. Perkel for quite some time. I'm retired military, had issues with prostate while on active duty. And when I retired, found out the urologist that I was seeing had retired. And I found Dr. Perkel, and he, it's a walking announcement to say that he's taking care of me with information and processes that would be a benefit to me. So one of the issues was that I was on the BPH meds, uroxetrol, and at the end of the day, it was like constant, pill taking. However, the results were minimal. I didn't really realize it until after questioning the process relative to the relief I was supposed to get from the meds. And so I went in to see Dr. Perkel for a regular visit, and he presented the process, Urolift, gave me all the information necessary to make an informed decision. And I gave him a thumbs up and say, yes, please. And needless to say, we had a couple pre-trials that a process that goes through before you do the procedure itself. And it further substantiated myself as a candidate. We scheduled the procedure. It was really relatively quick. I went in, I think it was toward the end of the week. I was like in and out. And when I got out, I didn't feel any real pressure as a result of the procedure itself. However, at the end of the day, I noticed a start of an uptake in the sense of benefit of the process. My stream was a little bit more forceful, in line with what Dr. Geary was speaking to, the fact that over the time you lose, pressure, and that was something I was aware of. And so that was something I noted as a result. And I'm post, procedure now. I've noted that it's continued to improve. So I'm totally optimistic that and fully endorse the process itself, the procedure, because I feel like it was definitely added benefit to do the procedure as opposed to have to maintain, say taking pills and not necessarily doing what they were prescribed to do. So again, I say I'm a walking advertisement for Urolift.
Thank you, Mr. Hogsett. We appreciate you sharing your story with us this morning. We do have a few questions that are coming in. I want to remind our journalists on the call, please submit those questions through the Zoom chat feature. We have about 10 minutes to take questions here on the call this morning. Dr. Perkel, I'm going to address the first question to you this morning. We've seen a lot of people who have delayed care because of COVID-19. They're worried about going to the hospital. They're worried about going into surgery or going to their doctor's office. What issues might result if a man delays care, and what is your practice doing to ensure that patients are COVID safe?
Right. Yeah, that's a question we get a lot too. And so we follow the ambulatory surgery guidelines in our surgery center, as does the hospital, where everyone gets a COVID-19 nasal swab or a testing, ideally within 3 days of surgery, but 3 to 7 days or 3 to 5 days before surgery. So that's reduce the risk of exposure from patient to patient, patient to staff, et cetera. You know, waiting a month or 2, 3 months for this type of thing, if somebody's urinating, probably isn't going to change the whole ball game. But you know, just delaying routine screening, prostate cancer screening, you know, could some of these BPH symptoms have something to do with something else? It's tough to just keep kicking the can down the road. When we were in March and we thought we'd be done with this by May 1st, you know, it wasn't a big deal, but here we are in August. So we have converted a lot to telehealth for things that lend themselves to that, or at least initial screening to just try to reduce the numbers of patients coming through the office. But some of these things, you know, depending on what's going on, you can't make it no risk, but you mitigate. Everyone's wearing masks. We're trying to disinfect surfaces more often, having cleaning crews and things. Making sure everybody washes their hands. Even before they come in our building, we have a hand washing station outside. So we're following all the CDC and Department of Community Health guidelines, but really it's an individual basis. I mean, especially if we screen with telehealth and we can say, okay, you know, this is what our initial proposal would be. When should we do it? That's a good way to do it. This is the actual device. Someone gave me one to show that it was a question of what it looks like. And it's very, very small. This is the UroLift implant. And typically there would be 2 to 4 holding back each lobe of the prostate. So I don't know if that shows up.
It does. Thank you, sir. All right, Dr. Geary, I'll address our next question to you. Dr. Perkel mentioned about 60 men who are in this study, but how many men do you treat on average with enlarged prostate or with bladder control issues?
That's a good question. The 60 men in the study it was a time-based, you know, within the last rolling calendar year that we needed to have in at the request of UroLift. Both of us have done over 100 of these procedures, well over 100, and probably just about every guy who comes in, if you ask the right questions, over age 50, sometimes even age 40, will start having some trouble with urination. And, you know, there's a lot of things you can do from a behavior standpoint without even medicine. You know, I always tell my patients that your bladder doesn't come with a user manual. And there's a lot of things people do wrong that they don't know. But for example, going pee 6 times a day is normal, somewhere between 5 and 7 if you're adequately hydrated, which most people in the Southeast aren't, which is why we treat so many kidney stones. So honestly, I see half women, half men in my practice because I focus mainly on the bladder, and the majority of the men that I see have some symptom that's bothering them, and a lot of them kind of feel relieved that it's okay to talk about it, and surprised to know that it's not something they're going to have to live with forever. The other thing to add to what Dr. Perkel was talking about, which I thought he covered beautifully, the one thing that all of my patients after a UroLift or a TURP, regardless of what we do to help them pee better, they all say, I wish I'd done this 5 years ago. And it's just that fear of having something done and that keeps people from doing anything. And that's kind of what we are hoping to get out, that the fear is unjustified. Everybody's got a horror story from what happened to their grandpa that they saw when they were kids. And it isn't like that anymore. So.
Mm-hmm. All right. And we have a follow-up question that goes along with something that you just mentioned. We've heard that prostate issues happen as men age. If a man doesn't develop symptoms in his 40s, 50s, 60s, is he likely to develop symptoms in his 70s or 80s?
You know, that's a great question. When somebody's going to develop things, I always tell them, I draw kind of like a bell curve. I have a tendency to draw a lot of stuff, but it's the same bell curve that you had in school where, you know, most people are going to get C's in school. You know, you got the bell curve and most people are going to get C's or B's. Some people get A's, some people get D's or F's. It's the same principle. Most guys are going to present with some symptoms around roughly age 50. But not all of them. Some guys don't have problems until they're in their 70s. I mean, you can prostate gland that doesn't grow in, it grows out. And so when you have a rectal exam or a finger check, the doctor may say, well, you've got a big gland, but they may not have any trouble peeing. And conversely, you can have guys that the doctor, well, it's not a very big prostate gland, and they can have massive symptoms. And that's one of the big kind of disnomers or disconnects sometimes between the urologist experience versus the primary care experience, where they go based on prostate size, because there used to be a lot of data to suggest that, oh, you need to have a big prostate gland in order to qualify for the certain medicine group, the 5ARI. But ultimately, you know, I think the guys that make it to 70 are lucky. I think that's great. I think the guys that have it at age 30 or 40, you know, it kind of stinks, but there's a lot you can do. And they're the ones, honestly, who benefit the most from the UroLift because of the absence of any sexual side effects, and they don't have to take pills. So, you know, all in all, there's a lot of progress made in the area, and men in particular can benefit a lot from the fact that we can make life better. And when your bladder quits working, when you start having trouble peeing, you know, you got to realize that's the very first decision or first thing that happens to you as a kid when you're getting potty trained, where you learn and you get positive feedback. And when that starts to kind of fall apart, subconsciously, it kind of makes you worry that everything else is going to go downhill too. So it bothers people way more than they even sometimes realize.
That's a really good point, Dr. Geary. We're taught that from a very early age. Dr. Perkel, I do have a question for you. So Mr. Hogsett mentioned some of the pills and other treatment options he was using prior to UroLift. What treatments were used in the past, and are those still effective today?
Right. So there's two classes of technically there's three classes of medicines now. There's one that's related to a blood pressure medicine, and that's the group of are called alpha blockers. The brand names used to be Flomax, Uroxetrol, Rapaflo, and they all usually end in osin, like tamsulosin or alfuzacin. So a lot of men are on those, and they relax the smooth muscle around the bladder neck and the prostate. They don't change the prostate size, but they do help with some of the symptoms and increase the flow rates. The problem is, as the prostate continues to grow, men usually find they become less effective, and they don't work for everybody. There's another class of drugs that Dr. Geary mentioned, the 5-ARIs, or 5-alpha reductase inhibitors. And those were called Proscar or Avodart, finasteride or dutasteride. And those have been associated with more sexual dysfunction. There's some concern in younger men about using those because of the way they interfere with testosterone pathway. They do shrink the size of the prostate because they actually cause some atrophy of the glandular tissue. the first class that I mentioned, one of the side effects that people don't like, they could have fatigue, dizziness, and also some problems with ejaculation with the fluid coming out. The last class is there is an indication for the same medicine that's in Cialis. It's called tadalafil. And so that can help with some of the urinary symptoms. But the problem is none of these fix the problem. So if somebody doesn't want to take a daily medicine, or they have a side effect, or they're on one medicine and it stops working and they're looking at adding a second medicine, it just doesn't necessarily make sense for everyone. Some people are very happy on medicine, and if it relieves their symptoms and they don't mind taking them and they don't have a side effect, then there's nothing wrong with it in most cases. Sometimes delaying the symptoms or reducing the symptoms just causes the bladder to get stronger, to push that urine through the water channel. And if you don't fix the problem, eventually the bladder gets to the point where it can only get so muscular, and then it starts to become less effective. When the bladder gets more muscular, it's also associated with more of the irritative urinary symptoms like frequency and urgency. So there is a sweet spot where we would like to intervene and fix the problem before the bladder decompensates. So that's the ideal place for intervention, but medicine is fine for some people.
All right, thank you. So our journalist on the call, we have just a few minutes left. So if you have any more questions, please go ahead and get those in through the chat feature. Mr. Hogsett,
Can I add something?
Yes, sir. Go ahead.
Can I add something to what Dr. Perkel said? He mentioned the 3 classes of medicine, and technically there's actually a 4th. The overactive bladder medicines that are traditionally used for women with overactive bladder symptoms of frequency, urgency, plus or minus incontinence are often very much applicable to men as well. Like you'll have guys that are taking up to 2, 3, 4 medicines to treat these symptoms, when you can have an outpatient minimally invasive surgery with no sexual side effects that's got great durability, and you can eliminate up to 4 medicines off of your med list, which we all know polypharmacy is a major, major problem these days. So something else to consider.
All right, thank you, Dr. Geary. Mr. Hogsett, a question for you. Is there anything that you would say to other men living here in Central Georgia, just as a final thought?
The main thing is having a good dialogue with your urologist, so you can find out what is out there in the way of treatment, and find out what best suits you. And again, as I said, I feel totally comfortable in having a conversation with Dr. Perkel, and I rely on him to give me what is the most, I guess, the latest technology that's out there. And that's really what I would suggest, is be aware that, you know, the technology has changed from what was, you know, say, when I was growing up, and, you know, say, as Dr. Geary spoke to, you hear the stories of prostate, I guess, issues and the outcomes not necessarily favorable. I think it's totally different now. And so in all aspects of life, but particularly as we're looking at the issue of urology, I just feel that there's so many things and that's there now. And I'm amazed, because, as I said, in my walk with Dr. Geary, Perkel, it's that everything that has come about. I mean, just even the first, I guess, procedure that he, you know, say, opened my eyes to. I said, wow, I didn't know that, you know. And so that's what I'm looking at. I say embrace, I guess, the technology that's out there, but more importantly, make sure you have a good dialogue with your urologist, and I think that pays dividends.
All right, great words of advice, Mr. Hogsett. Thank you. I'd like to thank all three of our panelists for joining us this morning. I'd also like to thank our journalists for joining us. It is Men's Health Month throughout the entire month of September. So if you have any men's health questions, feel free to give our office a call. I'll be more than happy to set you up with interviews with our expert physicians. Thank you guys so much. We appreciate your time, and I hope everyone has a great afternoon. Thank you.